Hello, everybody. Welcome to the Harm Reduction Report. This is your host, Willard T. Belly, Sandbagger News. It's a nice November Sunday evening. I'm here with your pal, Cal. Cal will introduce who our guest for the week's show is going to be.
Hi, welcome to the show, guys. We're going to go ahead and jump right into a recorded phone call with Dr. Kurt Datz about the opioid crisis that is currently stretching across America and throughout the world. Dr. Kurt Datz, DO, which stands for Doctor of Osteopathy, is board certified by the American Board of Internal Medicine. Dr. Datz received a DATA 2000 waiver, DATA standing for Drug Addiction Treatment Act, which was passed in 2000, and he treats opioid use disorder at his private practice in Bismarck, North Dakota. He utilizes Suboxone and medication-assisted treatment. Dr. Datz has offices in Bismarck, North Dakota, and will soon be opening an office in Grand Forks, North Dakota in January 2018.
And he's your dad.
Yes, he's my dad, and it's with great honor that, we have my dad, Dr. Kurt Datz, here to provide a medical perspective about his ideas and his experience with the opioid crisis. So, let's jump right into it.
Yeah, so I guess as I mentioned, did you get a chance to review those questions a little bit?
Yeah, I looked at them.
Okay. So yeah, as I mentioned, the opioid crisis is a bit of an epidemic, and it's kind of a big deal going on in the United States right now. So as a medical doctor, your input is really valuable and really important, and you have sort of an educated perspective about all those things, plus the firsthand experience there as a Suboxone provider. I think what a lot of viewers will not be aware of is what is Suboxone exactly. So I guess maybe would you be able to mention a little bit about what is Suboxone?
Yes, I think there's a lot of physicians that don't even know what it is. They're not familiar with it. Not that anyone's stupid, it's just ignorant. They
Right.
don't know what it is, but so it's a tablet or a film. It's a combination medication, and it's designed that way to prevent abuse of the medication. There's buprenorphine and naloxone, and that combination reduces the chance of anyone using it intravenously and then getting high from it.
Right.
So the naloxone is Narcan. We use that intravenously in the hospital whenever someone is given too much narcotics post-op, for example.
Mm-hmm.
But in the medication Suboxone, the naloxone has minimal absorption. It's not really available when you take it orally. So that's why when you see someone overdosing on a narcotic, they have to take it intravenous, they have to take it intramuscular, so there's an intranasal, prep for that. So when they ingest it orally, the buprenorphine is the active ingredient by mouth, the sublingual rather, and the naloxone is somewhat inert with minimal absorption, if any at all, orally. But if they try melting that down and injecting it, then it's not going to do anything because the mechanism of action of the naloxone is to occupy those opioid receptor sites, and so a narcotic is not going to be able to have any effect on the person.
Right.
So it makes me as a physician feel comfortable prescribing it because of that.
Right. That's a huge benefit. Yeah. I remember learning that the buprenorphine, as you mentioned, is the active ingredient in Suboxone, but it also has that naloxone. I remember reading that the buprenorphine attaches so hard to those opioid receptors in the brain and body that if a drug user was to take any other type of opiate, like heroin or oxycodone or hydrocodone or any of the other huge variety of opioids, that if a user was to take another opioid, it would basically just skip right over those opioid receptors because the buprenorphine latches onto those receptors with such great affinity. It's really magnetized to those receptors, so anything else is rendered useless. Any other opioid is rendered useless. And as you mentioned as well, that there's that naloxone in there, which is a deterrent from intravenous use, because, you know, if someone were to inject the naloxone, that they'd basically be launched into what is it, like precipitated withdrawals? Is that what it's called?
Yeah. So that's the precipitated withdrawal is more so with when you're talking about induction of buprenorphine and the patient has narcotic in their system. So that's what we call precipitated withdrawal. What you're talking about, though, is the naloxone having coming into the system and doing something similar, but displacing any of the narcotic and occupying that receptor site.
Right. Okay.
The difference there is, like, you know, the narcotic in the system, and you take buprenorphine, like you said, that has a high affinity for the receptor. So any narcotic sitting on the receptor is going to be thrown off because the buprenorphine wants that receptor because it has a higher affinity for it. And so it kicks off the narcotic and occupies the site. But because buprenorphine is only a partial agonist at that receptor, meaning it does not have a full opioid effect on the receptor, it occupies the receptor, but it has a weaker effect, then the person suddenly feels withdrawal because of that higher, you know, that more concentrated opioid being kicked off of the receptor suddenly. So that's what patients that come in for their first visit and they're buprenorphine naive, they don't know about it, and they haven't had it. You know, we want to make sure we get a baseline drug test on them, because if they're positive for opiates in the urine, then they need to wait till they're in withdrawal. Because withdrawal symptoms means they don't have any, you know, circulating or effective opioids on those receptors, and it'd be safe to take the first dose.
Okay.
I kind of explain that, like, to help them understand. I tell them that if you go into a movie theater and you have a whole bunch of people sitting in the chairs, you know, what the chairs represent the receptors, and the people sitting there is the buprenorphine, or is the hydrocodone, for example, oxycodone, hydrocodone. And then the next group of people come in, and they're stronger and they want those chairs, so they kick all those people out of the chairs, you know, and occupy it. So that's kind of what happens. And if that occurs and they have that's what is called precipitated withdrawal. That's a very severe form of withdrawal. You know, that's what I try avoiding. Because usually, if someone experiences that, then they're typically pretty, you know, wary of continuing with treatment. You know, so that's an important thing to educate the patient when they're first in there. And I tell them, I said, you know, like, because sometimes they'll come in line and they'll say they haven't had anything for the last month or something.
But really they have.
And they're obviously not in withdrawal. You know, they look comfortable. And so I tell them I don't really care what they did or when the last time they took anything, but, you know, if they're not in withdrawal, they're going to have this precipitated withdrawal if they don't wait till they metabolize the narcotic that they took that morning or the day before, you know.
Yeah, that fact right there kind of illustrates the danger of stigma. These people that come in seeking treatment, seeking help, are like fearful of being open and honest with their doctor. So that's kind of like one negative side effect of this negative stigma, which is, you know, kind of what we're hoping to address, is these negative stigma type things. So it sounds overall like Suboxone is a relatively safe drug, especially when used appropriately. And, you know, if we can educate people about how it works and why it's safe and the benefits and everything, then I think that stigma surrounding Suboxone and drug addiction in general and opioid addiction can be decreased. And I think people will be more likely to, you know, come into your office and tell you the truth and seek help and stuff like that. Because there's a big stigma around even seeking help, and even being on any medication at all is somewhat stigmatized. And we've talked about that a little bit in some of my classes. So that's kind of an interesting aspect. One question I wanted to ask you was, like, while you were speaking, it raised the question of, like, do you ever encounter like opposition to Suboxone? Do you ever experience like people saying, oh, you know, Suboxone isn't good, it's dangerous? basically you're enabling an opioid addict to stay an opioid addict and stuff like that. Do you ever encounter that?
Yeah, I see that. Like even physicians do that. Sometimes family members of the patient, where their wife or girlfriend does that, where they'll say you're just, replacing one drug for another drug, or even when they go to the pharmacy, patients will complain that they're not treated, professionally. They're treated poorly at the pharmacy.
Sure.
That's something that you see.
Okay. Yeah, it's funny. It's funny you mentioned that. I mean, even I remember encountering that stigma even in the case when I was in like Narcotics Anonymous classes. When I was sitting in those NA meetings, I remember there was a huge stigma even among people that were like recovering opioid addicts. I remember people thinking and sort of displaying this general tone of like, oh, you're not really clean. You're on Suboxone. You're just basically replacing one opioid with another. So I'm wondering, like, what exactly do you say to those people? Well, first of all, like, why do they have that idea? Why do you think they have that idea? Or what? And then what do you say to them after? Like when someone comes at you with a stigma like that, what are you supposed to say?
Yeah. So those, what we use Suboxone, it's in a situation called medication-assisted treatment. Mm-hmm. And that's not, there's two factors you're dealing with when you're talking about opioid use disorder or any addiction. You're talking about the physical symptoms and the physical issues, and you're talking, secondly, about the psychology of the disease. So it's easy to treat the physical symptoms. You just take your Suboxone. You're still normal, you're not drug-seeking, you're able to focus on, work, family, and so on. The problem is always the psychology of the disease, and that's why counseling, a chemical dependency evaluation and counseling, and aftercare is important. Mm-hmm. And I don't think that's something that has to be like a lifetime or a lifelong commitment, or I don't think it has to be so burdensome, that patients are at risk for losing their job and that kind of a thing. I think it has to be, it has to take place for patients to learn what are their triggers and how to manage them and so on. But, whenever you're taking Suboxone, you feel normal and you don't feel like you need to do the counseling. But the problem is there will be a trigger at some point. That might be someone, the death of a family member. It might be somebody that you used to use with, approaches you at a store and gets, asks you to come to a party or something. Mm-hmm. Or even watching something on TV, like Breaking Bad or something, and that triggers the person. So they need to understand those triggers, what they might be, and then how to manage them.
Right. So that's a good answer. Those are those psychological aspects that you were talking about, the triggers and stuff. So that's.
Yeah, but to answer your question about the stigma, not just with healthcare providers like doctors that don't understand this. I have patients coming in who say that their doctor tells them to get off the stuff.
Oh, okay. Wow.
I have patients coming in and saying that their girlfriend broke up with them because she didn't want him on anything, including Suboxone. So family members, girlfriends, wives do that. It's not extremely prevalent, but it's a significant concern. But to answer the question, there is evidence-based medicine that shows the use of Suboxone with medication-assisted treatment that includes the counseling. Those patients have lower rates of relapse. Mm-hmm. They have longer periods of sobriety. They're less likely to relapse. So whenever you're encountering someone at NA, what you don't know about that person in NA is how many days or weeks or months after he makes that statement, that ignorant statement about Suboxone, that he relapses himself.
Right. Yeah.
And even sometimes counselors, like whenever I send a patient to a counselor, sometimes the counselor will try getting them to taper off of the Suboxone.
Wow, that's interesting. A little bit like preemptively when they're not ready, huh?
Yeah, I mean, the Suboxone is something that can be used for 3 months, 6 months, or it can be used for, years.
Right.
It depends. It has to be individualized, and it depends on the person.
That's kind of interesting. I didn't realize there was even that stigma. That stigma was as prominent as it is. Like you mentioned, counselors suggesting that their patients taper, as soon as possible. That's kind of interesting.
Well, there's even some rehab programs that are completely drug-free, where if you go into the program to get treatment, you cannot be on Suboxone. So there even those exist. I think one of them here in town is Teen Challenge does that.
Okay.
I've had a couple patients go through that, and then they had to be off of the Suboxone. And that just puts them at risk for relapse, really.
Yeah. That's one thing I'd like to expand a little bit on what you mentioned. Like that's one thing. That's one way I like to explain it is, you covered the physical part, so Suboxone essentially allows you to put those physical aspects of withdrawal and drug addiction on hold. That way you can conquer the psychological component. As you had mentioned, someone who's on Suboxone for 10 years or whatever, they are able to get back into a normal routine and, go to school, learn, educate themselves, make new friends, meet new people, and basically create a whole new life for themselves. They're able to really focus on that psychological aspect of their addiction. And, if it works, do it. And that's one way I've always loved to explain it is that people oftentimes relapse, like they'll be totally in the clear of their physical withdrawal. They'll have gone through the withdrawal symptoms and they'll be done. They'll be fine. They'll, be getting back into the swing of things and on a job and, they'll have a job and everything. But those psychological aspects of addiction come creeping back in, 6 months down the line. And that's one of the wonderful things about Suboxone is that you can use it if you need for several years to sort of help separate, to help increase the time from your addiction to now. That way you have time to prepare for when those psychological triggers do creep back into your life at some point. You're more like, as you mentioned, you're more likely to have an extended period of sobriety. And I believe that that's one of the biggest things is that you're able to create a normal life around you during all that time that you're taking the Suboxone. And that is the huge advantage to Suboxone, in my opinion.
Yeah, it basically what it does in the short term is stabilizes the patient, immediately after 1 or 2 days they become, they feel normal again. But it immediately stabilizes the patient physically, from withdrawals. And it allows them then to focus on, regaining their family, maintaining employment, getting into counseling, So when I see somebody that's new in my program, I allow them 1, 2, or 3 months before I then, have them, I kind of force them into counseling to get a chemical dependency evaluation and then determine, counseling needs. Somebody that's already been in counseling, and some patients have been in 2, 3, 4 different programs that included counseling, and they understand what addiction is, they understand the triggers and everything, but they still are relapsing, So yeah. I don't always force them into it, just because you're dealing with the burden of the disease isn't just the health issues, but there's also economic issues to the patients where they're missing work. And then the employers find out they're on Suboxone, or employers don't like them missing work, and then, they lose their job, and then that just becomes another trigger, another risk for relapse,
Yeah. Cool. Okay, so I guess how do you witness, how it helps your patients? Do you see your patients changing over the course of time? And how do you feel? Yeah. It's very obviously a success to you.
Yeah, the things I use for successful treatment are things like, patients that come to me on the first visit and they do not have a job. Well, in my program, they have to have a job. They have to gain employment.
Okay.
Because it's an issue of self-esteem, self-worth. It's an issue of being able to take care of yourself. And sometimes young kids will come in and their parents are paying for their, visits and stuff, and I tell them, no, you need to get a job and you need to be paying for this. So they have to be employed, and it's a requirement of the program. But one of the things is that they're either now employed as a success, or if they're already employed, they're not missing any more work days,
Okay.
That would be successful. I have some patients who have started businesses, brand new businesses. One lady,
Wow.
started, her own business. Another guy started his own construction business, those kind of things. So those are the kind of things you look at with success. And then interaction with their family is, another monitor, another marker for success, that they, some of these mothers have lost custody of their children. They've had some of them in child protective services, and they're not allowed to see the parents. One lady hasn't seen her children for a year or 2 years because of prison and that kind of a thing. So she's hopeful to be able to petition the courts to start having visitation with the kids and, other mothers that are in that situation. Like the one lady was, her children will return to her, because she was in medication-assisted treatment. So there's things you look at and follow for success.
Right, to sort of operationally define success. That's kind of interesting. That's fascinating. That's kind of the message that I'm gearing towards, right now, is sort of spreading this perspective that, these people that are addicted to opioids are normal people with common values to the rest of society. They have similar values as those that are not addicted to opioids, and you can see that, when someone starts to create their own business and give back to society. And I think that's a really important thing. I'm glad you mentioned that, because that just goes to show how, having these rehabilitative options there for these people can assist them in contributing back to society, as opposed to pushing them down out into the streets, out onto the, outcasts of society, and labeling them as useless and having no value. Because as you've demonstrated and seen firsthand, that's not the case. These people can contribute, and they do. And when they have that option, when they're able to, kind of get back into the swing of things and get rehabilitated. So I'm really glad you mentioned that. That's a good point.
Mm-hmm. Yep.
I guess we can move on to the next question I have here. I just have a couple more. One that I want to ask is do you think personally that there's enough availability for Suboxone?
Well, no, I don't think so. I think part of the issue there is, physicians not wanting to prescribe it.
Mm-hmm.
And I think that's part of the stigma, associated with the disorder. Physicians don't want to be labeled that way.
Right. Like guilty by association.
So we don't have,
almost.
there's only a handful of doctors in North Dakota that are prescribing it. The other problem is the federal government itself, the regulations, the way they limit the number of patients you can see. They limited it initially to 30 patients in your first year of treatment. And then after the first year, you have to apply to increase that to 100 patients a year, or 100 patients on a monthly basis, total of 100. And then most recently, they allowed an increase to 275. So, there's regulations associated with it that kind of make it difficult. But it's more lenient than a methadone clinic. So this is office-based treatment with Suboxone. And methadone, you have to have a special federal license to prescribe methadone, so physicians cannot do that for the purpose of opioid use disorder without that special license, with the methadone clinic.
That brings up kind of another really interesting topic is, what are your thoughts about methadone? How come Suboxone over methadone?
Well, first of all, methadone's been around for decades, and it's established, but the way that has to be dispensed is it creates a real barrier for patients who have to go there every day to the methadone clinic to get their daily dose.
Okay.
And eventually, after 2 years of, being in the methadone clinic, they graduate to being allowed to take home a month's supply, but that's 2 years later.
Okay.
So office-based treatment with Suboxone allows the physician to assess the appropriateness of that patient being given a monthly dose, right away. Sometimes I'll bring patients back in a week or 2 weeks, but most of the time I'll bring them back in a month.
Mm-hmm.
And so it's a lot easier for patients, to maintain sobriety that way without the burden of those daily visits.
Yeah. Yeah, I remember within the opioid using community, I remember hearing sort of this echo of how methadone can be abused. I've heard how methadone is abused by some, and basically they point towards the euphoric effects that methadone can produce anyways. It's probably, not as desirable as other opioids like heroin and OxyContin and everything. And there's a place for methadone, of course, in treatment, in the treatment scene. So, but
it has a long half-life, so the fact that it has a long half-life makes it easier to use for the indication of opioid use disorder, but that's also makes an overdose especially hazardous.
Okay.
Half-life. Methadone, where a hydrocodone overdose or overdose of oxycodone, you may just need to take one dose of Narcan intranasal, and then, the patient recovers. Well, when you have a methadone that has a 40-hour to 60-hour half-life, then you're looking at, frequent dosing of Narcan,
Sure.
It's more risky that way.
Yeah.
But it has its its place in treatment. I just think one of the drawbacks is the way the methadone clinics are designed to be a daily visit for the patient.
Something else that just came to mind was this ceiling effect.
The other thing too, I forgot, is that it can be abused.
Yeah.
Abused and diverted. People can sell it, but that's kind of one of the reasons they do the daily.
So that they take it right there.
Yeah.
So does methadone have the ceiling effect?
The what?
The ceiling effect. Do you know anything about that?
Yeah, I'd have to look that up. Meaning after so much it doesn't work?
Yeah, I believe that's what it is. I was gonna mention it on last week's episode, and I think I maybe even did, but I believe, if I'm not mistaken, that the ceiling effect is essentially there's only so much dosage that's required with Suboxone. At some point the excess dosage is just wasted. It no longer gets you any, higher, for lack of a better term, or doesn't attach to any more receptors or whatever. I don't know exactly how it works.
Yeah, once you take so much of it, your receptors are saturated. So
right, and I believe that was one of the superior aspects to Suboxone over methadone. I don't think methadone necessarily has that ceiling effect. I'll have to double check. I'll look into that, I guess, before I say that on air. But
yeah. The difference is buprenorphine, like I said before, it's a partial agonist. So it only partially activates the receptor. It has some analgesic effect, but a person's not going to get high from it.
Right.
Methadone, like heroin, is a full agonist, so they can use that,
So that is one huge advantage to Suboxone. That's what I was kind of getting at, is that with methadone it can be abused. You can pretty much get high on it. You take more and more and more, and, some of those people, they end up high. They end up abusing the methadone, whereas with Suboxone, you can't really do that.
And actually, to answer your question, I just looked this up while we were talking.
Okay.
Buprenorphine has a ceiling effect, and it has a better safety profile. Methadone does not have a ceiling effect. And they're saying here that that's useful in patients that are dependent on high doses of opioids.
Mm-hmm.
So methadone and heroin do not have a ceiling effect.
Okay. Interesting. Okay. Cool. One last question I have is, what do you think, what kind of things can be done to combat the opioid crisis? Like, the opioid crisis here in America and around the world is very obviously a big thing. It's damaging lives, ruining families, and it's negatively impacting society. So, that's one reason I'm so happy to have you here on the air and be covering this topic is it's something that needs to be addressed, something, we need to explore how we can combat this issue. So I guess my question is, what kinds of things can help combat that opioid crisis that we're in the middle of?
I think one of the problems was whenever medical societies said, that patients are entitled to treatment of pain, and they identified pain as the fifth vital sign. And if a physician isn't treating a patient's pain, then they're exposing themselves to, lawsuits and things like that. So I think the pendulum swung the other way because physicians who then treated pain, me being one of them, but I don't feel like I ever overprescribed. I think I was always appropriate with prescribing it, but that's not true of all of us. But I think the pendulum is swinging the other way and has, where we're saying you have to be careful how you're treating that patient's pain. And I think the biggest issue is still physicians, because even now, when my patients go, even though I educate the patients and I tell them they're not allowed to be on a narcotic for any reason, but the point is any oral agent, any oral narcotic that is being used for pain management post-op, no matter what the procedure is, if it's an oral agent, hydrocodone, oxycodone, whatever it might be, I can use Suboxone in a higher dose to treat their pain, So I see dentists and I see physicians still, my patients going in, and they go to the dentist, and the dentist knows they're on Suboxone. And unless I call the dentist ahead of time and know, then the patient uniformly will get prescribed hydrocodone,
Okay.
And the patient will sometimes take the prescription, get it filled, and then whenever I do the database, the prescription drug monitoring program database evaluation, and I see that in the database, and I ask the patients about it, and they'll always say, oh yeah, the dentist gave it to me, I didn't know what it was, or I went to the pharmacy, and it was there, and, my mom picked it up for me because I was at home, So you have the problem with the patient complying, and I make it really clear to the patients that they're putting themselves at risk, not just for relapse, but I'm going to kick them out of the program if that's what they're going to do, because it also puts me at risk, my program and my license, and that's one of the other problems with this, with treating people with opioid use disorder, is if I can't get them to comply in my program and I get audited, because the DEA does audit, prescribers of Suboxone, and I'm found to not being, following regulations and things like that for whatever reason, then my license can be placed at risk.
Yeah.
So these patients that are the dentists and the physicians who are ignorant of what Suboxone is, or who maybe genuinely think the patient needs to be on pain medication, and everyone deserves to have pain treated, especially post-op pain. But again, it does not need to be with a prescription narcotic. I've treated sinus surgeries, nasal reconstruction, C-sections, appendectomies, anything that is post-op can be treated with Suboxone, and patients come back and say they were fine with that treatment, So whenever I have a dentist that does that, or a physician that does that, writing hydrocodone, or sometimes, most recently, the patient went in with a pneumonia and was prescribed codeine, as a cough suppressant. I end up having to write a letter to the dentist or a letter to the physician, letting them know that they shouldn't do that in a patient that has opioid use disorder that's on Suboxone, because they're placing them at risk for a relapse. Not to mention in exposing themselves to discipline, by their state board for not being aware of that, and prescribing it. And I even got in trouble with the state board one time because I had a patient who was diagnosed with lymphoma and was receiving chemotherapy, and he was being prescribed hydrocodone by his oncologist, and I told him multiple times not to take hydrocodone, and at that time the physicians were only required to do the database search once a year. and without a reason to do it more frequently, I didn't do it more frequently on this patient.
Mm-hmm.
Well, so the oncologist who felt like the patient needed treated for pain was given hydrocodone, and then here I am prescribed Suboxone.
Okay.
Well, the pharmacist who was filling the prescriptions, both hydrocodone and Suboxone, you think the pharmacist would have picked up the phone and said, "Hey, Dr. Datz, there's a problem here because you're prescribing Suboxone to this patient and Dr. So-and-so is prescribing hydrocodone, Well, instead of the pharmacist being a team player and, helping to control diversion, because the guy may have been selling his Suboxone, or selling the hydrocodone, I don't know. Or he may have been taking both of them. But instead of being a team player and, trying to make sure that the patient was treated properly, he reported me to the state board,
Okay.
And, the problem with, I was found, I didn't do anything wrong because I did the database, I addressed the issue, I basically terminated the patient. I said, look, actually I didn't, I did terminate him, but he kind of like did not return for treatment, and I terminated him because of that.
Okay.
But the worst thing you can do, I think, for the patient, like I have a couple other patients that have like metastatic prostate cancer who are also addicted. So they're on, higher doses of Suboxone because I am, also treating their pain. But this one patient, he still was the guy that was given hydrocodone, and he knows not to take it. So he brought it to me. He brought the prescription to me unfilled, and I shredded it and wrote a letter to the doctor. And then another time, his doctor gave him, he's the one that the doctor gave him a codeine cough suppressant, and he didn't know codeine was even in it. He didn't even know that. So I had to write that letter. But that's kind of a real problem because that's one of the biggest issues is physicians. I think physicians are kind of at they kind of hold the bag for a lot of this crisis that we're in. Not exclusively, but a lot of what we see with the opioid crisis starts out with innocent and medically indicated prescription narcotics, but then instead of the doctor recognizing, hey, your acute pain shouldn't be still acute pain, 6 weeks, 8 weeks, 12 weeks later, as the patient keeps coming back, and they keep prescribing it to them. That's one of the problems. And then the other problem is, you have a patient that is in treatment, that is interested in complying, and you still have these healthcare providers who are prescribing them narcotics still. Part of it's educational. A lot of the healthcare providers need to be educated on what this is.
Yeah.
Because they don't really know about it.
Yeah, there's it sounds like there's many different factors that contribute to the opioid epidemic, that being a big one, obviously. We might have to do a whole nother episode about how the war on drugs helps contribute to the opioid crisis and other issues, other drug-related issues. But so maybe we'll have you for a whole nother. Maybe we'll have you answer a couple questions on that at a later time. I think for this one we're going to keep it. I think we got some good material here, and I think that answers most of my questions here. We'll have to. There's so much to cover. There's a ton of contributing factors and a lot to consider. And this war on drugs, it just contributes negatively to society in the end, I believe. And a lot of us with the Students for Sensible Drug Policy believe, and that's why you see this movement of radio shows, people speaking out, giving speeches, and doctors coming out and talking about the stigma and just all kinds of different things. And it's a really interesting topic, and we're happy to have you. Thanks. This is Dr. Kurt Datz. Thanks for coming and speaking today, for being on the show. Thanks for sharing your thoughts and speaking out and going public with it. It's kind of a big hurdle or a big task sometimes, but we appreciate it. It's good. I think each time somebody speaks out, then somebody else will feel comfortable speaking out about what they've seen and their experience and the truth that they perceive. So it was very very useful, very valuable to have you on here as a experienced doctor with firsthand experience with this kind of stuff. So thanks.
Well, it's my pleasure to be able to give you my perspective, and I think having students taking an interest in harm reduction and bringing awareness to what college students and adult patients outside of the school system have to deal with. I think that's really important.
Sweet. Wonderful. The wonderful Dr. Kurt Datz, everybody.
That's Kurt Datz. Thank you very much, Cal, for getting your father to chat with us about his perspective. Did you have a good time talking to him?
Yeah, that was a great conversation. It was really fun. Tackled some really complicated issues that have a lot of factors involved. It was a very fluid and flowing conversation, just simply because of how impactful this topic is. And there's finding a solution to this opioid crisis is really important, and that's part of, you could hear it in my dad's fluidity as well during the conversation, that he has passion behind this and that he believes in what he's doing. He believes in this medication called Suboxone, and that is, I'm really grateful that he came on the air and gave his medical perspective about that, because I've encountered that stigma and sort of just that lack of knowledge about Suboxone so many times. And oftentimes I kind of hold my tongue, because I don't want to disagree with people, but I do. I think it's a very useful medication. And, it maybe isn't necessarily for everybody, but Suboxone has really saved my life. It saved a lot of people's lives. And as I mentioned before, my motto about Suboxone has kind of become, if it works, do it. If it works for you, then that's what you do.
What is that? How did you develop that motto exactly? What do you mean, just Suboxone?
Yeah, if like Suboxone, so part of where that motto comes from, the reason that came to be was in my interactions with people, so often hearing that people described Suboxone as the devil, or as like something very dangerous, or that it's addictive. It's basically heroin and stuff like that. And instead of arguing against that, I thought to myself, maybe it is, maybe it can be that to some people. That might be true in some cases, but in my case, it worked. It worked for me, so my motto became, if it works, then do it. And that's kind of what I've used to explain to people how, why I believe in Suboxone.
Yeah, it was nice to hear your dad say, it was nice and not nice to hear him say that he has experienced, stigma about it. That's not productive stigma, but something that gets in the way of how physicians do their work. Like, I was under the impression that was going on, but to hear a doctor say that is a good reminder that it must probably be, at least from one doctor's perspective, it is going on. So that's, I don't know. It was kind of nice to hear him say that, but also too bad that he's dealing with those problems too.
I thought that was fascinating when he was talking about how, counselors and physicians even urge their patients to get off Suboxone or to not try it in the first place. And he told a story about how a Suboxone patient had a girlfriend who didn't believe in Suboxone, and they broke up or whatever. She wanted him to get off of Suboxone, and it's unfortunate because Suboxone helps people. It helps so many people, and that was just very interesting, very fascinating to see that stigma exists even within the realm of those medical doctors and physicians and counselors and whatnot.
How do you think his relationship to you and you kind of found Suboxone together, didn't you?
Right, yeah. So as I mentioned in the introductory episode, last episode, I had an opioid addiction, and that's how I found myself on Suboxone. But I had never really heard that much about Suboxone in my using days, my opioid using days. It was really my dad that came to me with Suboxone and the knowledge of Suboxone, and he scheduled my appointment for me and everything. And I don't think he knew a whole lot about it at that time either, but he knew that there was some buzz going on about Suboxone, and he probably looked into a few success stories and stuff like that. So this was before he was prescribing Suboxone. I got onto Suboxone with he had heard of Suboxone, and referred me to a doctor and scheduled the appointment, and then from there he watched how Suboxone changed my life, how I was able to utilize Suboxone efficiently and effectively to help my recovery and my sobriety. And from there he gained great interest in Suboxone, and I think, I've heard him say that that's a large part of where his interest in Suboxone came from. Of course, there are surely other things as well. I mean, there's statistical information about how useful Suboxone is, and as he mentioned in the audio recording, how statistically people on Suboxone will tend to have greater periods of sobriety than people who are on methadone, or people who simply take the all-natural route of just cold turkey quitting their opioid use. You remember there was that conversation about how opioid addiction, an opioid addict might recover from the physical withdrawal component, but still 6 months down the line relapse because there's a trigger. And, it was very interesting to hear him say that. I'm glad he brought that up in the interview. It was interesting because it's a good point. The longer that you've abstained from opioid use, then the more likely you are to stay sober. If you're completely clean for 6 months, that's good, but it's only 6 months. And the advantage of Suboxone for me has been that I was able to have no opioid usage for 7 years. So the psychological dangers, those psychological triggers are going to be 7 years developed. I'm going to have 7 years defense on my side against those triggers.
Yes, you've had some more practice dealing with that.
Yeah, 7 years of
with
practice
the time
versus 6 months. Yeah.
And keeping in mind that relapse is going to be an expected part of people's process.
Yeah.
Your dad said when they're on Suboxone, they relapse less. That's basically what he said, right?
Correct, yeah.
Yeah. Yeah, well, that seems to make sense if it's that support that you describe.
Yeah.
My friend James was in the MAPS MDMA study for treatment-resistant PTSD. James Casey, who founded the Psychedelic Club, and he just that treatment's very different from how your Suboxone works.
Yeah, very
because
much so.
you take your Suboxone home with you.
Yep, every day, take it every day.
That's what the patients do. James, with the MDMA phase 2 study, they just had him do it with a doctor, with a team of therapists, 3 times, 2 weeks apart, and then never again. So he never did it outside of supervision as part of his treatment, and he never, did it a lot or did it regularly. He was supposed to 3 times he was done, and he described it like the MDMA as a suit of armor that allowed his therapist then to walk him into the trauma that he experienced that they then talked about, and while he was wearing this suit of armor, he could get into this dark place and talk about it and start actually associating those memories with a little bit of good vibes, and then that's how you treat yourself with that.
Yeah.
So it's different because Suboxone you don't just do once while you're in the presence of a doctor, and it's a lot less psychoactive than MDMA is. But how would you say it felt? James called his MDMA in that sense a suit of armor, so that he didn't have to worry about the physical damage to his self going into those memories, but he could focus on the treatment. Would you say something like Suboxone is almost armor or something that puts off the physical symptoms that you can just think about it?
Yeah, I suppose in some ways I can connect with that analogy and relate it to Suboxone.
Perhaps a different analogy is better.
It's sort of like a buffer, a safety net kind of a thing. I'm imagining, had I gone through opioid withdrawals without Suboxone, I'm imagining my likelihood of relapse would have been much, much greater. I'm just imagining, when you're in those withdrawals, when I was in those withdrawals, the knowledge that all I had to do was make a phone call or go get some of those dangerous opioids to feel better, that was something that's always in the back of your mind. And so this Suboxone, brought me back to baseline, and I guess I could compare that to a suit of armor. Yeah, I felt very comfortable. It felt very safe, and I just was able to stop thinking about opioids altogether so much more easily. I was able to stop thinking about opioids, and that's a big thing. That's a huge thing for opioid addicts. In opioid addiction, you think about your opiates all day, every day. Like that's what you do. That's part of the disease. That's part of the condition. That's part of what you experience. So that was really good. Mm-hmm. Very helpful. Suit of armor.
Imagine, so we, since last week, have officially applied for our to host a session at the Students for Sensible Drug Policy Conference in Baltimore this March.
Very exciting.
With Dr. Kurt Datz, our very own pal Cal Datz, and our professor and faculty advisor and homie Frank White from UND, talking about sort of what you guys were just talking about in that phone call. Do you think you'll have another conversation or two with your dad before, let's say we actually do get selected and we go to talk about this some more? It'd be nice to see Frank's input and see how that affects the conversation. Mm-hmm. But do you anticipate your dad having different ideas or certain things he'll want to focus on? What will you want to focus on if we're sitting in a room with all the drug policy people and students? And what do you really want to get across to them about your story with your dad?
Yeah, I think a lot of the same topics will surface. I'm very excited to get out there and be speaking to a receptive audience that we're going to have at SSDP. Obviously, the audience will be consisting of people that share sort of that similar understanding and sort of that similar knowledge base. So a lot of those topics will resurface, and I think along the way we're going to develop our ideas and maybe even review that conversation a little bit. Something you hit on about relapse being normal that my dad and I did not cover in that conversation. It'd be fun. It'd be very useful to develop that idea and get his understanding of, how normal is relapse, what happens during relapse, because that's a gray area. And, every doctor may or may not treat that differently. I'm not sure exactly. They're probably like very rigid guidelines about relapse within a Suboxone clinic. But, as you mentioned, relapse is normal. And I relapsed many times and during my recovery at the very beginning. And it's been 7 years since I've relapsed. But at the very beginning, it was off to a little bit of a rocky start. And I'm so glad that I had that grace period of relapse, because had relapse not been accepted as a normal part of recovery, I would have been kicked off Suboxone and I would have been left to fend for myself. So I think that, adopting the idea that relapse is going to happen, instead of saying that someone who relapses doesn't really want to be clean, that's not the truth. I wanted to be clean, but I relapsed nonetheless. So I'm very grateful to have had that grace there, that forgivingness. That'd be great to convey during the conference.
That armor of Suboxone helped a little bit with that relapse period.
Yes, it did, absolutely.
Well, we're going to be learning more about this stuff here next week. We are speaking in Frank White's Drugs and Society class on campus at UND. Maybe we'll post the room numbers if he doesn't mind anybody coming, but
yeah.
Bet my mom shows up. She comes to those kinds of things. I love that. But that's going to be fun. We got to figure out what to say. We're meeting with a group on campus called Students for Opioid Solutions, which is looking to change legislation in the state to allow state employees at the university here to carry Narcan, the naloxone opioid antidote. And something else going on this week is Thursday. You should check out at the Christus Rex Lutheran Center, connected to the Archives Coffee House on University Avenue in good old G-Funk. there's something called Thirsty for Justice Thursdays, with hosted by Kylie Overson. And this week, or I think they do it every week, their topic is addiction, and they're going to have Frank White speaking about addiction and as it relates to being thirsty for justice. So that sounds like a good time. We're going to be there probably recording some things that might be a part of next week's episode. But check that out and listen again next week to the Harm Reduction Report. We are always developing... Right, it's okay. We are always developing our ideas and hoping to hear from you. So please respond or send us messages on Facebook on the Sandbagger News page and also on sandbaggernews.org, where the Harm Reduction Report old episodes can be found. So thank you very much. And Cal, thank you. Thank you, your dad, again for us.
Sure.
And we'll both see you again soon. Sandbag on, everybody.
Sandbag on.